Thank you, Tina. So Sean, would you please introduce yourself?
Yeah. Bonjour. My name is Sean Middleton, and I work in the behavioral health home program here at NACC.
Miigwech. Michelle?
Hi, everybody. I'm Michelle Corcoran. I'm the nurse manager for the MAT program here at NACC. Thanks for joining us.
Miigwech. Tina?
My name is Tina. I'm the non-medical HIV case manager here at NACC.
Miigwech. And I'm Kari Robbie. I'm medical officer and a family practice and addiction medicine physician here at NACC, and I work primarily in the MAT program, my clinical work. I'm going to go ahead and start the program. So this is again the Midwest Tribal Echo. Welcome. Next slide, please. So we've already had our prayer and land acknowledgement with Sean. Thank you so much, Sean. I'm doing the introductions and agenda. I'm going to go through Zoom guidelines. Tina will be doing the announcement. Michelle will be doing our didactic today and a case presentation if we have time, and then we'll close. So we're all pretty familiar with Zoom at this point in the pandemic, but please introduce yourself in the chat function, use with your name, title, organization, and email. You can also on your screen right-click and update your name so that we can read who you are on the screen. Next slide. We will really do appreciate it if people turn on their cameras so we can see you. We don't mind if you're eating lunch or whatever you're doing. We understand we're all multitasking. It just makes the conversation flow more easily if we can see each other. We do ask that you mute your microphone when you're not speaking. If there's noise coming from your microphone, we might mute you. Please don't take offense. If you'd like to ask a question or you need attention, please use the chat or the hand raise function. And as always, no protected health information, please. Tina, would you do the announcements?
I will. So just as a reminder, we meet every first and third Wednesday of the month from noon until 1 p.m. Upcoming echoes include February 2nd. The outreach team at NACC will be talking about syringe exchange and harm reduction services. And then on February 19th, Susan Bolio from the U of M will be talking about her research around ACEs and historical trauma. This other echo happens the first and third Tuesday of each month from 12:15 to 1:15. It's the Opioid Use Disorder Education and Treatment Echo Series with Dr. Heather Bell and Dr. Kurt Devine. And they also did a an MOUD treatment virtual boot camp. That was a live boot camp, but there was a recording and I've heard that it was really helpful. So the link is on this presentation, but if you'd like it, please let me know and I can send it to you directly. Case presentations are included. We try to have them at the end of each echo if there's time. We don't always have time because we like to save time for the didactic and discussion. But anyone is welcome and encouraged to send us case presentations or clinical questions. It's a great time to discuss your questions and concerns in a group setting. If you have a case presentation you want to present, please just send me an email and we can connect about that. Continuing education credits are offered for this session. In order to receive those, you'll have to complete the survey that I send out after the session. So please complete that survey. And if you have questions, just reach out to me and I can get you connected to our CME people. And I'm going to now hand it over to Michelle and she will present.
Okay, so I'll just let you know, Tina, when it's okay to go to the next slide.
Sounds good.
It might be pretty obvious though. So today I'm going to be talking about dual pathway buprenorphine naloxone. A lot of people tend to think about buprenorphine as, either given as a prescription or given, at an OTP or a methadone clinic. But at NACC, we kind of have two pathways, which is unique and also pretty cool. Next slide. I don't have any financial interests, and I'm not discussing off-label use of medications. I didn't know if this needed to be in here, Tina, so threw it in. Objectives today. So I am the nurse manager for the MAT program, both the Direct Prescribe and the dosing program here at NACC. And so I'm just going to chat with you a little bit about some, buprenorphine and kind of MAT. We don't use that word anymore. I'll explain in a minute, but MAT history and that sort of thing. So the objectives will be talking about different pathways, benefits and limitations, kind of defining what dosing is in Direct Prescribe and how they can be used together in a dual pathway program. And that kind of helps us meet the needs of more patients. And then describing how NACC utilizes harm reduction principles and then the chronic care model when we prescribe buprenorphine. Just some interesting kind of things about kind of addiction and how we manage it. It wasn't really seen as a moral failing. It didn't really become kind of a bad thing until immigrants and then poor whites began to really struggle with it in the 20th century. Prior to that, it was mostly women. It was, like a women's issue, hysteria, that sort of thing. And then soldiers, they were really treated with sympathy and were given morphine as maintenance therapy to manage their substance use. There was a shift away from the medical management and it became kind of a law enforcement approach, and it restricted how opiates were used in, over-the-counter products. I think we've all seen, cough medicines and things with, opiates in them. And it really kind of made it a crime. And so they did things like maintain a narcotics registry to monitor people that were known or suspected to have addiction. And just a lot of laws and restrictions were placed. And then at that time, it made it actually illegal for providers to give opiates to their patients to help them manage withdrawal symptoms and cravings and things like that. So this law enforcement approach really kind of changed things. And so their, addiction was not being managed. People were not doing very well. And there was kind of a need for medications to really manage opioid use disorder. So kind of became a public health concern in the 60s. There was a large increase in substance use related deaths and then also crime. And that's when they kind of came upon methadone. And so that was found to be a good alternative to using morphine or heroin for maintenance programs because of its longer half-life and things we, look at like the decreased euphoria and sedation. Suboxone and Subutex began being used in 2002. Prior to that, it had been used just in like a really low dose as an injection for pain management. Next slide. And then we came to the data, the Drug Addiction Treatment Act of 2000. So that was created really to allow providers to prescribe FDA-approved medications for opioid use disorder outside of an OTP or an opioid treatment program. And the goal was to increase access. So we've really been kind of shifting the way we think about substance use disorders and kind of getting away from that law enforcement approach that we know doesn't work very well. And, they really decided that some medications don't require the same level of oversight that methadone does. And so now we use buprenorphine monoproduct, and along with naloxone, and those are the only medications right now prescribed under this, kind of waiver. And there's 15,700 waivered providers right now in the US, which I kind of expected there to be more, but we're working on it, right? So there have been a lot of ongoing changes, and I think, we've seen it even at NACC, and just how the medications are being prescribed and used. And so some things that are happening, and this is really kind of exciting stuff to see. So providers now can prescribe buprenorphine without completing waiver training. So without completing waiver training, without, really indicating or saying that you can provide behavioral health services and things like that, you can prescribe to up to 30 patients. Now that doesn't count towards your first year of prescribing. But basically the point is they really want to increase access. They want just about anybody to be able to prescribe buprenorphine. And then there are some situations where they'll let you prescribe to 100 patients in that first year, rather than making you do 30 for the first year. Primary care providers and emergency departments are really being encouraged to prescribe. And then SAMHSA even has made it kind of okay or recommended to use telehealth to really reach people who can't get to clinics and whatnot for services. The DEA has even made some approvals for providers to obtain the buprenorphine themselves to administer to patients in places where there's like pharmacy deserts and things like that. So that's been pretty cool. Really, it's nice to see, other organizations really pushing the medication first model and kind of recognizing the need to increase access. So go ahead into the next slide, Tina. So buprenorphine naloxone, it's a safe and effective medication. This is not anything new, I'm sure, to most of you. And it doesn't really need to be administered in an OTP or an opioid treatment program, and it doesn't require the same level of monitoring that methadone does. The medication itself decreases risk of overdose, and it reduces, and even at good doses, eliminates cravings completely. So it's a partial agonist. I know people who aren't familiar with the medication often have concerns about it being dangerous, and it's not a full agonist, so it's got less of the effects that a full agonist would have, and a much longer half-life. So, less respiratory depression, less euphoria and sedation, and a lot less potential for misuse, which is really important. And really kind of a lot of folks are starting to recognize that the diversion risk with Suboxone or with buprenorphine products really tends to be people sharing their medication with those who are also trying to manage their opioid use disorder. So it's not diverted to help people get high, it's diverted to help each other out, and help folks get through their withdrawal symptoms and their cravings. We don't see a lot of diversion, and when we do, what we kind of the fear would be that people are selling their Suboxone so that they can buy other substances, and we just don't see that a lot. So this, I am super excited about this. So terminology used by SAMHSA. So medication assisted treatment, that's what we're pretty familiar with, MAT. That's really no longer used. So the change that they've come up with really kind of better reflects the benefits and then the use of the medication. So MAT implies that the medication is a supplement to the more important treatment. So it's kind of an afterthought or secondary to the treatment. And we're now using, or they recommend using, MOUD, medications for opioid use disorder. So that supports the understanding that the medication can be used alone to improve and manage symptoms. So I think of this very kind of the same way I would think about antidepressants. We don't call antidepressants, MAT, or medication assisted treatment for depression. We call them antidepressants, medications for depression, because even on their own, they are helpful to the management of the condition. They're not just a supplement to something else. So I'm excited by this terminology change. I know that it's not going to, mean much in the short term, but I think in the long term, it's really going to help people kind of think differently about the medication. And, I'm certainly not saying that treatment isn't beneficial, because I think it certainly is. just like with depression or other things, right? Medication and therapy together really are, what we would want everyone to do. And it's just not always feasible at any given moment for some patients. So recovery can start to happen even with just the medication. So next slide. And why? Why is there this big push to get more Suboxone, more buprenorphine to more people? Here's some slides that I think most of us have seen. So opioid-related overdose deaths, have increased, right? They're increasing everywhere, and we all know this. And medications for opioid use disorder are known to help, and so it would make sense then you get this medicine out to more people. The more people are saved, essentially, right? Decreased deaths. And the next slide. Specifically with our patients, again, I think I'm not saying anything that people don't already know. In Minnesota, American Indians are 7 times more likely to die from a drug overdose when compared to whites. So, I mean, 7 times, that's pretty significant. And so, that's really prompted kind of a push for us at NACC to really get more medication out there, get more access to services out there for people. Next slide. So dual pathway, MOUD. So patients might benefit from one program over another, and that's based a lot on where they are in the stages of change, what they've done for other therapies, things like that. So on one hand, we have daily dosing. So that's, medications given in the clinic. That's similar to the opioid treatment programs, that methadone clinic that most people are familiar with. It works really well for someone who's in need of a little bit of support, but also it works well for patients. Oh, there we go. Who struggle to keep appointments and do well with a more walk-in type of dosing. It can be a good option too for people who are unstably housed and don't necessarily want to try and keep track of a big chunk of medication. It's given in the clinic each day with the nurse. One thing that can kind of be a barrier for some people is a chemical health assessment, an intake, comprehensive assessment, things. There's all kinds of requirements to get into a traditional daily dosing program or an OTP. At NACC, we've kind of developed a program a little outside of the box, and we have waitlist dosing and ways that we can get patients medication. We can start them right away and keep it as low barrier as possible while they're working on some of those things. The direct prescribe can be even less barrier. Basically, if patients can come in, they can get Suboxone. So it can be a really good option for patients who are really stable. Patients, some come in once a month, they get their prescriptions, they're doing really great. Maybe they've completed all kinds of programming, or they've gotten kind of stable on their own, and they're kind of in that maintenance phase or maintenance stage of change. It can also be a good option for people who aren't ready to commit to a program or a plan. So the dosing program is a program, and not everybody's ready to be a part of a program. Direct prescribe can be helpful in those situations as well. So the patient picks up their medication at the pharmacy and they take it on their own. And there's not really any requirements outside of, getting to the clinic. And you have to be seen in order to get your medication and that sort of thing. So what we've done at NACC that I think has worked really well is patients have the option of both. And I'll go into that a little bit more. Next slide. What are we working on? Oh, stages of change. Yes, everybody has seen the stages of change. So we see patients quite often go in and out of these stages. And generally what happens though, and I love this new addition to the stages of change, there's an upward spiral. So most of us are very familiar with the stages, and we see this in practice, right? We see this with our patients. Each relapse is different, right? A patient may have a use episode, but it's just a use episode. It's not a full relapse. And so as they're moving in and out of these stages, they are continuing to move upward. Generally, that's what we hope, right? And so having two pathways for Suboxone allows the patient to go kind of between the two models based on where they're at, what stage they're in at that particular time. One thing we do with our daily dosing, for example, is it's not as long-term as a traditional methadone clinic or an OTP. If you go to any of the daily dosing clinics that most of us are familiar with, everything's based on your eutoxes, right? If you have a use episode or a positive eutox, then you're one step back from getting carryouts and things like that. And we've been able to do things a little bit differently and base it on other things and other factors that show success. So, next slide. Thank you. So MOUD at NACC. All patients, meet with the provider and the nurse. All patients come in the same way. So regardless of the program, the patient receives primary care if they want it, and they also receive RN care coordination. So they come in, they complete an intake, and they go through their physical, mental, chemical, social health history. We screen for infectious disease risk, social supports that might be needed, things like that. And we also talk with the patient about whether or not there's legal involvement, outstanding referrals to treatment, and things like that. So most patients, when they come in to see us, they get a prescription. And we really do this same day, right? We know that getting medication to patients is very important, right? So they're given the prescription and they start the Direct Prescribe program. Occasionally, somebody will come in, already have been referred to our dosing program, or they might say they want the dosing program. We see that quite a bit. The flexibility of a dosing program can be really great for folks who maybe have a job and they don't want to do outpatient, or they don't want to do inpatient, but they want something. So that can be super helpful. What we like to do is get folks started and then determine, what their needs are. So if somebody comes in and they're in withdrawal, or they've recently used, that may not be a good time to really determine what's going to be the best course of action for them. So we like to get them started, get them feeling a little bit better, and then we can work with them to figure out what their needs are, and then help them focus on figuring out what their needs are when their opioid receptors aren't in, full panic mode. Okay. Next slide. And I'm going through this kind of fast, sorry. So I think overall, we've all done a really good job in chemical health to really recognize that addiction or substance use disorders are complex chronic health conditions. We haven't quite figured out how to manage them as chronic health conditions. So I think we tend to, I think we're kind of contributing to the stigma by treating it or managing it separately or differently. So I think we're definitely making progress, and recent changes to, recommendations through SAMHSA and increasing access, I think are certainly helping with this. And, if you just this slide, I just kind of compare it to diabetes, right? So if a provider told the patient with diabetes, well, hey, you really need insulin, but I'm not going to give it to you because you're not engaged in a program, right? Or you're not able to complete the intake to do this exercise and diet program, so therefore I'm not going to give you your insulin. That would be unethical. We don't do that, but yet we do that with opioid use disorder. We want patients to do things or meet certain criteria before we give them the medication. Really, I'm just saying, hey, look, the medication first model works really well. And then having multiple pathways to help the patient, regardless of whether they're super stable or super unstable and anywhere in between. Dr. Robbie likes to use the term shimmering. When patients are shimmering, we want to make sure that they're still able to get access to the supports and services and medications that they need. So my conclusion, next slide, I think this is the last one. So buprenorphine, we know it's effective. We know that it's safe. It's most effective when it's used along with other supports, right? Treatment, therapy, social supports, housing, things like that. But it's also effective as a standalone treatment. So really the recommendation from SAMHSA now at this point is basically difficulties or resistance from the patient in connecting them with counseling or other services or resources should not prevent providers from prescribing buprenorphine. There's really a push to get more providers prescribing buprenorphine, whether that's primary care, emergency departments, really anywhere that there is, provider-patient interaction. It's an opportunity to talk about, these medications. So having multiple pathways, multiple opportunities for patients to express concerns or talk about their opioid use allows you to serve a wider variety of patients. And then really, medication first allows the patient the space to kind of figure out what stage of change they're in. It's really hard to figure out what stage of change you're in when you're in, the cycle of use and withdrawal, not feeling well and that sort of thing. And so medication first. Then I've just got some references or resources on the last slide, and that is it. Might be the quickest presentation ever.
Thank you, Michelle. That was nice to hear our program gone through so comprehensively. Any questions from anybody about the concept of daily dosing or having sort of a dual things offered, or how we make our decisions or anything like that?
I am curious. I lost your reference page there at the end. Is there a way I could get a copy of that?
Oh, sure. I'm sure we could email that out.
Thank
Yep,
you very much.
I think that you put your email in here and send it to you.
Thanks. Also curious, if you have a client that's in active use of another substance, does that stop you from prescribing at all?
No.
Yeah,
No.
Well,
No.
I
We
bet
take it-
Dr. Robbie wants to clarify.
Yeah, we take it into consideration. So so if somebody is using benzos, for example, it makes a difference if they're using chaotically versus if they're prescribed. If they're using benzos kind of in a non-controlled way, we sort of, we have a conversation with them about it. We talk about detox, all of those things as potential thoughts. But we have had a couple patients who are just like, I don't want to go to detox. They don't want to do it like that. And so then we'll just have them come and see us weekly. It used to be with Suboxone and benzos. They used to say it was a contraindications for benzos and alcohol. So those are the two that I'm the most worried about because they have a synergistic effect with the buprenorphine, but it's still better than heroin and alcohol or heroin and benzos. So that's kind of our approach. And then and sort of more support, making sure that there's support there. I think that benzos are in my opinion, benzos are almost always problematic. So it's about having the conversations and sort of, but also meeting the client where they're at and seeing what they would like to do. As far as other substances like meth, again, we just provide the support. Our LIDCs will try and have them meet with them, but it doesn't stop us from prescribing. Those are the big ones we see. We also see cocaine sometimes. We don't even test for marijuana. And we allow the client to sort of self-describe how much of a problem that is for them.
One thing I will say kind of along with that, it's very common that we have patients who also use meth. I mean, a lot of us see patients who use opiates and meth. And I think generally patients continue to use meth for a while. And maybe want to continue to use that, maybe don't really have an intention to stop using, or maybe do want to. Generally, they come in, they want to get a handle on the opiates, right? Like that's the thing they really want to get a handle on. And oftentimes the meth use starts to decrease as they're doing programming, or as they're coming in, or just as things start to stabilize for them, they just start to use less.
Yeah, and you know, like the more chaotic somebody is, the more likely we're going to ask them, we're going to suggest the dosing program for them, and then they can really access the supports of the LADC, the elder and residents, all of the other services that we offer through the dosing clinic, and that helps to stabilize them and help them to start to make choices towards better health.
And maybe somebody here knows, I had a colleague say to me that they knew someone that was prescribed Suboxone for a stimulant use disorder, methamphetamine specifically. I attempted to research this and see if it was approved for that, and I did not see that it was.
It is not approved for that, but we have definitely, we have never prescribed it specifically for meth, but we did, like, you know, in the many patients that we prescribed for, there was one in particular that I can think of that who like used opiates, but it was that by no means her drug of choice. Meth was, and she said it really helped her with her meth cravings. And I think that anecdotally, as Michelle said, meth use seems to decrease on the Suboxone. So that's my sense of it. It's not, you know, we also have patients who use Suboxone for a long time and continue to use meth.
Yeah, I was just curious if it had been approved or not.
It is not approved. I don't think there's any approved medication, a medication for meth. There's a lot of anecdotal things. A lot of, you know, tried this, tried gabapentin, tried something else, but there's Wellbutrin, but nothing is approved. Yeah.
I think definitely anecdotally, you know, patients report when they're just when their opioid cravings are decreased, their kind of cravings for other things start to decrease too.
And our patients also described to us that, you know, with the opiates, it's like it never lets up. You know, they can never just, you know, they can't take a break from it. It just it's a driver. Like, and especially the fentanyl. We had one patient tell us, you know, as you're getting high, you're already trying to plan your next dose because you're going to crash, and then you're not going to be able to think. And so it's just they get really trapped in the cycle of like. Of trying to always thinking of their next dose and how they're going to get through the next day, the next whatever. They can't do they can't do anything. They're very, very stuck in the cycle of finding the fentanyl, using it, starting to withdraw, finding it, you know, all of that. Yes, Dustin.
Yeah, and in the spirit of that too, the way that you're just talking about it right now is, in fact, the way that people, in some ways, it can be conceptualized that the meth use and the fentanyl use is a kind of attempt at medication, self-medication. So the idea that Suboxone or Buprenorphine is an addition to their medication repertoire, and then it's a collaboration that we're now joining them in terms of their interest and using medication. And so that relationship is sort of joining with them the way Michelle talked about, so that our relationship to healthcare, it might be that meth use changes when they establish a relationship to healthcare, to the doctor, to the nurse, to the clinic, and it starts to become a kind of self-investment in a relationship that impacts the substance use. So it's still very much a therapy, I think, because the relationship is still part of that prescribing of the buprenorphine.
Thank you, Dustin.
One thing I wanted to kind of, add to this, I think NACC is in a unique position in that we had a direct prescribe program, and then we're able to create a daily dosing program. And I know not everybody has the ability to do that. However, I think it's helpful to think about it more like relationship building. So if you do prescribe and you just do prescriptions, establishing a relationship with a dosing program, so that you can do a warm handoff, right, for patients. So if you get to a point where you're not able to meet the patient's needs, or for some reason you can't continue to prescribe to them, instead of saying, oh, sorry, you're on your own, really being able to connect them immediately to a dosing program to try and make it as seamless as possible. So you can, continue to prescribe until they do their intake. Whereas I think it'd be a lot easier for clinics who have dosing programs already to also do prescriptions. Because you've already got a prescriber, you've already got nurses, you've already got, kind of that infrastructure. So I think just being able to kind of seamlessly transition between the two is really helpful.
Mhm. Absolutely. Any final questions? I'm very excited. It seems like we might get to our case presentation today.
You guys are going to be so sick of hearing me talk.
I doubt that. So, and last chance for questions, and then we're going to start our case presentation. Okay.
Gosh, I can't believe we're finally getting to do it.
It's been a while.
It has. So this is a young male in his early 20s, was stable on Suboxone 12 milligrams for over a year, was doing really well. Working full time, got his own place, and then decided like he was doing so great he didn't need Suboxone anymore, and he quickly tapered himself down to 2 milligrams, which proved to really not be enough. And he relapsed and began smoking fentanyl multiple times per day, and kind of found himself, like Dr. Robbie was saying, in that cycle of just having to use fentanyl so often. And prior to being on Suboxone, he had never used fentanyl. So this is a new thing. So we had done prescriptions, we had done in-clinic microinductions many times. He did complete one and get back up to a stable dose, but that was really short-lived, didn't last for very long. And he's been unable to not use for more than 24 hours. So we haven't been able to do a macro induction. So it's lots of attempts at the micro inductions. He's had difficulty keeping appointments. And when he does come in, he's often under the influence. So how much of the treatment plan is being remembered and things like that. So he is still employed and still has housing, but is at risk of losing both. And there's no legal involvement. There's really no desire to engage in programming. He's not ordered to engage in programming. And he doesn't have any sober supports outside of his family. So all of his friends use, and for most of us, friends are really important. He's young, in his 20s, spends a lot of time with his friends. Many of his family members are sober though. And one kind of complicating factor with this is there's type 1 diabetes, which is hard to manage if you're not, taking medications on a regular basis and that sort of thing. So I'm just, how can we support him through a micro induction? Are there other induction things people have tried? Does anybody have suggestions, thoughts, that sort of thing?
I have a question. Why is he trying to be sober? What's driving him to continue to try it? So how many times? It looks like he's tried a lot of different times.
Oh gosh, I want to say
Why-
we've
what's his-
done. Well, he says that he doesn't want to use, and he doesn't want to be, he like wants his life back, is how he describes it. There's a reluctance to do treatment because he thinks that he can get a handle on it on his own, right? Like if I just do this, then everything will be okay, and I'll be back on my regular dose, and everything will go back to normal. But he says he's tired of using, he's tired of being sick, tired of fentanyl controlling him.
Are you able to do Sublocade?
We have not done Sublocade yet. We've been looking for the right person to start with, but my understanding with Sublocade is that you kind of need to have some stability, at least on the Suboxone, before you can think about transitioning to the Sublocade.
Yes, I was just curious whether you had
Oh,
started using it yet.
So much want to try it. Have you?
Here at OBAT, yes, they do.
Yeah, maybe I've considered going and shadowing somebody just so I can get some comfort with it.
Dr. Gran would be delighted, I'm sure.
I thank you. That will reignite our interest. Thank you, Valerie.
Oh, absolutely.
We ask patients all the time, and they all are just like, absolutely not, no way. And we haven't really been able to find anybody who wants to try it.
People are afraid of the unfamiliar. Something
Yep.
I found helpful is to tell people to go on Reddit. There are a lot of, there's a Soul subreddit devoted to people who are on Sublocade who talk about their experience.
That's a helpful suggestion. Also, I think the reason that I'd like to do a shadow is because then I think that sometimes providers are also afraid of the unknown. Also, we haven't figured out it's the process also figuring out how to get it paid for that we need to figure out from that end. So there's like a few different moving pieces with it. So yeah. Or is it getting paid for at your clinic, Valerie?
How is it?
Is it getting paid for? Is insurance covering it?
Yes.
Mhm.
Yes, I'm not an insurance person, so I can't give you any gory details, but I know it's being covered. And as you know, most of our clients are medical assistants, so
Mhm. Mhm. We will do some further work in that direction.
I think that Sublocade would be great for a lot of people. I think once people get stable, I hear a lot that they're just sick of having to take Suboxone every day.
Yeah.
Like, when am I going to be done with this? Having to do this every day. So if anybody has someone or knows somebody who wants it and you work at NACC, send them our direction.
also people say that it's a more steady
Yeah.
dosing experience. It doesn't tend to roll you up and down the way Suboxone does.
It's pretty cool. So with our with our young man who's not able to get through micro inductions, is anybody doing micro inductions or macro inductions at this point? Or is it just us?
They are doing them here, but I'm not the right person to talk to. Well, I'm in the methadone clinic, not OBAT, so it's not my wheelhouse.
Valerie, have you seen them transition from the methadone to Suboxone?
Yes,
Do they do that via microinduction, or how are they doing that?
I'm not sure that that's exactly the right term. I have had clients who have just brought their methadone dose down low, 30-ish, and then go on to Suboxone for a few days and then move on to Sublocade.
Okay.
So you go directly from 30 milligrams to Suboxone?
Yes. With the goal of moving on to generally Sublocade. In my
Right.
experience, of course, other people just want to be on Suboxone, but it's just been my experience that that has not been the end goal.
Do you know what, so like when you guys, and I apologize if you don't know the answer, how are you getting people started on Suboxone or buprenorphine when they've been using fentanyl?
That would definitely be a Dr. Grand question, and I'm sure that, I can certainly let him know to contact you all, and I know that he would be
Yeah.
happy to share that information, and I think that he actually did some echoes about that.
Yeah.
So they should be archived on the Hennepin site, and that would be my apology for not knowing all of this. That's why I'm here, is that I don't always try to learn more.
No, I'm just curious about, I mean,
Other people are doing it, yeah.
yeah, who's doing what and what's working and what's not. And, I think we see this sometimes. So these micro inductions, it's 0.5 milligram twice a day and then 1 milligram twice a day. And then you oftentimes have to continue to use while you're doing it. And I think this young man is a perfect example of somebody who's just not able to do that. And we see that sometimes where the 5 days of the small doses of increasing Suboxone while trying to manage withdrawal symptoms with use is really hard.
Yeah. And then we've done a dual track where we'll start them on the microinduction, and then if they choose to try to not use for 24 hours, then we can sometimes switch them over to a macroinduction, which in our experience seems to work okay without precipitated withdrawal if you've gone 24 hours without use, which is a big dose of Suboxone, 32 milligrams. And that will sometimes work for people who just can't stick through a 5-day microinduction, but are able to get through 24 hours. But this sounds like this guy hasn't even been able to do that. I'm curious, Dustin, I don't mean to put you on the spot, but is there anything like, as far as like somebody who's like stuck in a cycle like this, is there any kind of like stick you put in the gears?
Yeah, I mean, I think the big picture is sort of, I think there's a couple of really interesting components to the discussion. One is the Michelle mentioning the sort of chronic nature, and that we're looking for sort of treatment or intervention or medical attention that takes place over a long period of time. And so I think it's helpful to conceptualize him coming in and it not really working as part of an actual continuum, as opposed to, well, each one of those is a failure. There might be ways that that you're actually building up a relationship and moving towards success. And so going back to that we want to be able to, in the medical field, say, this is the problem, here's the solution, prescribe the solution, and then chart it and say, look what we've done. So I think there's ways that we're wanting to kind of stay with him, and wondering what to do next. I also think there's this way that you look at the dual pathways that Michelle's talking about, is that we've often had this sort of one-way ramp, I think, where that says, well, if they can't dose, then they need more attention, right? They need more medical care. We need to refer them to residential or inpatient. And as we ramp up what we think that they need more of, it oftentimes pushes them away from all of it. And so the Sublocade, or the Direct Prescribe, is interesting because we start to actually, if you think of like a Sublocade as like once a month, I don't know how often you inject, but it's just that point of contact. So we're having this small amount of contact with this person, and we want to see what we can do within that. Understanding the rest of his world is highly involved with things that are not really in our control. And so we start to look for, I really am sitting here wondering, wow, I wonder if we tend to think you can only get to Sublocade if you're stable. We tend to think you can only get direct prescribe if you're stable, which then leaves all these people out. And so I'm sort of curious about ways that we could increase what we can do within that window of contact that we have, which is really a small part of somebody's life. I mean, it's 10, 20 minutes here in the clinic. So I don't have an exact like mechanism. I would say, I guess I go back to the relationship. What's working? Like, what kind of successes are we having with them? If we looked at that data, that sheet, we looked at all these sort of problems. Let's rewrite that sheet to what he's doing good, and look at, oh, he's having a hard time coming in. Let's look, wow, he was able to come in twice this month. That would be the first step that I think about. Is that it's not maybe exactly what you want, but that's what's going on with me now in this moment, looking at this case.
I think that makes a lot of sense. And sometimes it's hard to practice what you preach, right? So looking at that stage of change, or the stages of change and the upward spiral, right? And so maybe this is somebody who's going in and out of these stages and is moving upward, but not recognizing it. Do you know what I think it's exactly what you're saying, right? So kind of taking big picture out, there is improvement, there is progress being made and connection being made, right? Because Dr. Ravi, the opposite of, what is it? Addiction is connection.
Addiction is not sobriety. The opposite of addiction is connection.
There we go.
And in that perspective, what we're looking at then is his substance use is kind of self-medication. So we start to imagine, what is it? What kind of pain is this painkiller killing? And so you can actually turn it into looking at the person is taking medications themselves because they're working on something. What are they working on? What are they trying to? And we tend to just think, oh, well, no, they're just working. It's all the drug. If they get rid of the drug, then they'll be okay. That's the exact opposite of what reality is. You get rid of the drug and then you have the problem that the drug was medicating. So then we want to conceptualize, what is that problem? What is that pain that he's using fentanyl to cope with?
Yeah. And it kind of, I'm thinking too, something that might be helpful, and I don't know that has been done with him, and something that we maybe need to do more often is comfort meds. And I'm noticing that patients tend to feel better and are better able to get through withdrawal just knowing that they have these medications available to help them if they need them. So I'll have to take a look at that.
That's a great thing. I mean, it both it epitomizes a relationship that we would want with them, that we're providing a comfort experience, not an increase in anxiety of what you should and have to do and what we see what's wrong with you. And those medications, in fact, actually help that. So I think that's a great, I think we kind of arrived at a pretty important, very simple thing right there.
I'd like to add that I would love to be able to see people travel outside the metro to see their families without getting cut off from their support, their medical support. They need to go and get their family support, and many journeys to return to use begin with that because they don't factor that in. And why would you? You're going to see your family. So
Completely. We see that as well. So we're almost at time. We're gonna end soon. So thank you so much for the presentation today, Michelle, and for finally doing a case presentation with us. And we look forward to seeing you all in a couple of weeks. What's the date, Tina?
February 2nd is the next echo.
And the topic is it
Topic
Susan?
No, Susan Bolio will be February 19th.
Oh, it's our outreach team. Yes,
Mhm.
that's exciting. Okay, well, we'll hope to see you all then. Have a great day.